Sir, as it has been commonly discussed, how common you come across the osmotic demyelination syndrome? Sir?
I haven't. I've seen a couple of cases during my training in PGH Chandigarh. After that, I have not come across because mostly I'm doing outpatient practice. I'm not dealing with inpatients, so I'm not handling acute hyponatremia patients.
Yeah, rarely we see, but sometimes the symptoms is a delayed onset, maybe 2 to 3 weeks. So if the patient doesn't come for follow-up, we may miss it. Or sometimes the patient expires before it develops. It's rare only.
Steve, can you provide us some more details about hyponatremia in adrenal insufficiency and hypothyroidism?
I showed there are various mechanisms how the adrenal and thyroid control the sodium metabolism. So adrenal insufficiency, there are various mechanisms. One is it can act on through the aldosterone mechanism. Aldosterone, we know that it retains the sodium and sends out the potassium. So in adrenal insufficiency, you get hyponatremia with hyperkalemia. So once you get hyponatremia with hyperkalemia, that can point towards adrenal insufficiency. Another thing is both cortisol and thyroid hormone are required for free water clearance. For the ADH, antidiuretic hormone or vasopressin to work, you need a supportive role of cortisol and thyroxine. So without this, water will not get excreted well. That's why if you see hypothyroid patients, they have fluid retention. So these two are required for free water clearance. So in both the ways, they retain more water in the blood, and once water is there, sodium gets diluted.
What about prevalence of hyponatremia in secondary adrenal insufficiency?
In secondary adrenal insufficiency also we get, madam, but what you are telling is the aldosterone pathway is spared in secondary adrenal insufficiency. So in that case also, there is some overlap between the glucocorticoid and mineralocorticoid action. So there also we get hyponatremia with hyperkalemia.
So we have seen many commonalities in this discussion. So hyponatremia, hypokalemia, hypocalcemia, all these three things, we have to first rule out whether it is pseudo or true. That is very, very important. So we have to repeat the test, or we have to check the background of the patient to confirm ourselves whether we are treating with a true setup. That is the next thing. And next thing, that is all the three electrolytes have the commonality of acute and chronic presentation. So we have to be sure whether it is an acute or a chronic setup we are treating. And other important commonality is the treatment parameter. So when you are treating also, we should not over-treat and we should not under-treat. That is common to all these electrolytes. That is very important. And as all the speakers have very clearly made up, the summary, we take home the message of this, the electrolyte session is, first we have to recheck whether the lab values are correct. So pray God, the results come again as normal. So that is the first thing as clinicians we normally expect. And next thing after that, they told that we have to assess the osmolality. So we break our head, what is osmolality, what is osmolarity? And then we come to a conclusion, okay. Then after that, when we have to assess the volume status of the patient. So volume status, again, we have to find out whether it is hypervolemic, euvolemic, or hypovolemic. So that also is a clinician's nightmare. After that, we have to come to the urinary sodium excretion. So we have to prove ourselves that we are an astute clinician by ordering a urinary sodium excretion to a lab, that too in front of attenders. And we have to prove ourselves that we are astute clinicians. And finally, we come to the conclusion, as usual, sir has told, the commonest cause is SAADH. So we come to a conclusion, okay, they remove the cause for the SAADH so that the hyponatremia will get it corrected. Or if we are not coming to any conclusion, finally we call our nephrologist friend, and he, as usual, mocks us, and you end with nothing to do with this patient, conservative management. So that is how we finally, clinicians as physicians, we end our electrolyte management. But now we have come to a very good deliberation of hyponatremia, hypokalemia, and hypocalcemia management by our expert clinicians. Thank you, sir.
Thank you, chairpersons for.
Sir, one question. Sir.
The last question. There is a tremendous use of SGLT2 inhibitors nowadays by various specialties. What is the electrolyte problems you come across, or is the to be highlighted, or electrolyte problems with the SGLT2 inhibitor therapies?
SGLT2 inhibitors, the electrolyte problem, only thing is the hyponatremia was there initially considered. Only thing, if somebody is using diuretics parallelly prior to starting, you may need to consider reducing the dose of diuretics. Routine monitoring of electrolytes is not advised. Only thing is you need to be cautious, vigilant, and maybe reduce the other drugs dosages if required. Especially in elderly, we routinely use.
Thank you, sir.
Commonly, we use the thiazides along with the hypertension drugs in the management, sir. So, in that patient, is there any role for be cautious with the SGLT2 inhibitors? Sir?
The thiazides, you mean?
Yes, sir. Yes, sir.
Yeah.
Thiazide SGLT interaction.
See, that's what I said. It is one, we are more worried about the hypotension. Loop diuretics routinely not many patients use as a routine management for as an antihypertensive agent. So the risk of hyponatremia is not a significant problem. Only thing is the risk of hypotension is a problem, and postural hypotension to be precise. So that is where you need to reduce the dose slightly of the diuretic whenever you are starting the SGLT2 inhibitor. Yes. That is important.
Thank you, sir.
Thank you, sir. Thank you for the great discussion as well. I would like to honor the speakers. First, Dr. Vivekanand sir can give the memento to Dr. Sivan Arulselvan sir. Vivekanand sir, please. I would like to call Venkatesh sir to honor Dr. KVS Harikumar sir. Vivekanand sir can give memento to Dr. Vijay Bhaskar sir. We would like to invite Dr. Gopinath sir to honor our chairpersons. To Vivekanand sir and to Venkatesh sir. Thank you, sir. Thank you for the wonderful session. And we are breaking for tea now. We will assemble at 4:35 p.m. exactly to start the last symposia.